Hi, welcome to this video on the history taking and examination for a case of malignancy of the oral cavity. To start off, we take a look at the history. We have to ask for the name, age, sex, the occupation and the residence of the patient. Then the chief complaint that the patient comes with complaints of ulcer or lesion in the mouth and the onset, like it's of insidious onset, and the duration, how long this swelling has there been for, swelling or lesion or ulcer has been there for, and the progression, that it was of this size and has rapidly or gradually progressed to the present size. Then we ask for the history of any sudden increase in size, then history of pain, like the duration, nature, whether it is continuous or intermittent, and the type of pain, any aggravating or relieving factors, and any radiation of pain. Does it disturb the sleep or affect his or her daily activities? Because painful lesions often imply malignant invasion into nearby peripheral nerves, otherwise malignancy is painless. Any history of bleeding from the ulcer, history of smoking, alcoholism, tobacco use, areca nut use, frequency, duration of all these things. The history of caries, tooths, sharp teeth and loose teeth. If there's any history of syphilis infection or any history of white or red patches in the mouth antedating the ulcer, which is indicative of leukoplakia, erythroplakia and melanoplakia. Or if there's any history of occupational exposure to heavy metals such as nickel and previous radiation exposure to the head and neck. These were the history about the cause of the ulcer, what led to the ulcer, if there's anything we can look for. Then the problems that the ulcer can give in the oral cavity, like history of difficulty in chewing or difficulty opening the mouth, difficulty in swallowing or pain during swallowing, drooling of saliva, excessive salivation, halitosis, that is bad smell, foul smell, and change in speech or hoarseness of voice. Then ask for history relevant with metastasis of the cancer, like history of cough, wheeze, hemoptysis or chest pain, history of lump or pain in the abdomen, history of bone pains, or history of weight loss or loss of appetite. Then ask for history of enlarged swellings in the neck or other adjacent areas, history of any treatment taken for the present disease, history of diabetes, hypertension, asthma and allergy. Then in the personal history, you ask if the patient is married and how many children he or she has. In females, you ask for the obstetric history and the LMP. Then the family history, particularly if any family members have had similar complaints, and then the socio-economic history. This history taking was not complete. If you want the complete basic history taking, you check out my other video, the link for which I have added in the description. Then coming to general examination, again, if you want to see the proper video on general examination, you check out my previous video on general examination, the link for which is in the description below. But in this case of malignancy of the oral cavity, you particularly also look for signs of vitamin deficiencies. In the systemic examination, you do the respiratory system, cardiovascular system, CNS and the abdomen. But particularly in such cases of malignancy, don't forget to mention about added breath sounds in respiratory system examination, because these are suggestive of lung metastasis. And do comment on presence or absence of lump and organomegaly, because these are suggestive of abdominal metastasis. Coming to local examination. The local examination is done first by inspection using a tongue blade. So we will start off with examining the intraoral examination by looking at the ulceroproliferative growth, the number of it, whether it's 1 or 2 or 3, number, size, shape, location. Location is commented with respect to teeth, the edge, floor, surrounding skin of the ulcer, infiltrating the skin, the exact extent of lesion, and whether it is crossing or encroaching the GB sulcus is to be commented upon. We have to look for restriction in mouth opening, because trismus suggests ominous pterygoid and masticator space involvement. We have to look for any patches of leukoplakia, erythroplakia or melanoplakia. And the occlusion, the number of absent teeth, caries, oral hygiene, and occlusal cant, that is whether this thing is horizontal or tilted. Then comment on the dentition, whether it is complete or partial, or if the patient is edentulous. If there's any synchronous lesion on the floor, palate, retromolar, trigone or the pharynx, You put the tongue out, ask the patient to put the tongue out and demonstrate the mobility of the tongue. Do the extraoral examination and comment on the fullness in the region adjacent to ulcer in the mouth. Any fullness in the neck for the lymph nodes. Inspect possible flap donor sites and comment this as possible flap donor sites inspected and found adequate. A complete examination of the cranial nerves is then performed, emphasizing sensation over the chin, tongue mobility for hypoglossal nerve deficit, facial nerve function, palatal elevation and gag reflex and function of the accessory nerve. Then you do the palpation, check for the temperature, tenderness, anesthesia in the infraorbital and inferior alveolar nerve territories. Measure the mouth opening, that is the interincisor distance. Palpate the ulcer and comment on the surface consistency, tenderness, extent of skin involved, extent of bone involved, extent of mucosal involvement, and fixity to the underlying structures. The method of palpation is borne by using the thumb and index finger of the right hand to feel the lingual and buccal cortex of the mandible. Test the lingual nerve and the chorda tympani nerve. Check for loose tooth, tenderness in the teeth, TM joint tenderness and deformity. Palpate the neck systematically for neck nodes. Palpate for possible face and neck vessels for microvascular anastomosis if a free flap is to be used. Then comment on the opposite side, like opposite side is normal. The diagnosis is made like this. Ulceroproliferative growth of this region, probably squamous cell carcinoma of this DNM grade of this stage, with or without complications. In the management, first we go with the investigations. The edge or punch biopsy of the ulcer is done to confirm the diagnosis. FNAC of the lymph nodes is to be done to confirm for neck metastasis. Indirect laryngoscopy to rule out synchronous malignancies because these are present in 5% cases. An OPG, orthopentamogram, is done to evaluate the involvement of mandible, status of dentition, site and size of mental foramen, to determine the site of cuts for mandibular resections or excess osteotomies, to confirm adequacy of reduction and fixation of excess osteotomies. CT scan is to be done to evaluate precise extent of involvement. MRI is done to look for soft tissue involvement. Chest X-ray to rule out lung metastasis. Ultrasound abdomen to rule out liver metastasis. Routine blood investigations and ECG for fitness for surgery. Bone scan for possible bony involvement of mandible or other bone mets. A barium swallow is to be done to rule out tongue-based lesions. And next is the treatment, which depends on your case and what your plan is. Thank you so much for watching. I hope you enjoyed it. If there's any query or opinion that you would like to share, please do so in the comment. Like the video and do subscribe to the channel. Thank you for watching.